Hello everyone and welcome to my progress report of 9 months and the long-awaited last presentation before the lunch break. My name is Róbert Vass and the topic I'll be discussing today is the inflammatory processes of the urinary tract and its association with genitourinary cancers. First, I would like to summarize our first project in a few sentences, which is nearing its completion. So, women have a 1.1% risk in their lifetime to develop bladder cancer, which has an overall mortality of approximately 35 to 40% within 5 years. Parallel with this, 10% of women also have recurrent urinary tract infections, which might be a risk factor for bladder cancer. Given that there are prophylactic methods to decrease the number of UTIs, it has crucial importance to understand the association between UTIs and bladder cancer. In our systematic review and meta-analysis, we showed that women who have more than 10 UTIs have 44% increased odds of developing bladder cancer. Therefore, these women should be candidates for prophylactic treatments and may also need to be followed more closely. Further research needs to focus on the effectiveness of these prophylactic treatments. So with that out of the way, my name, as I've said, is Róbert Vass. I'm a resident doctor at the Department of Urology and a first-year PhD student. And our vision is to reduce the incidence of genitourinary cancers, and we believe that the first step to do this is to identify risk factors. So we have two ongoing projects which are very similar, but one is on an epidemiologic scale, while the other is more on the metagenomic scale. So for our first project, we are investigating the effect of lower urinary tract infections on the incidence rate of bladder cancer in women. And as I've stated earlier, bladder cancer is not a rare disease. In fact, 1 in 89 women develop it. And while it is true that the incidence of bladder cancer is higher in men, women tend to present with a more advanced disease at the time of diagnosis. Several risk factors have been well documented in the case of bladder cancer, with smoking accounting for the highest number of preventable cases. But there is also a very specific infection called schistosomiasis. It is an infection with the blood fluke schistosoma hematobium, which does increase the risk of bladder cancer as well. There is also some evidence that regular bacterial UTIs are a risk factor for bladder cancer. And this last statement has a very high impact because nearly or half of all women will have at least one UTI during their life. A quarter of those women will have recurrent UTIs, putting the whole number of women worldwide who will ever have a recurrent UTI up to the 100 millions. So it is imperative to answer the question whether frequent lower UTIs increase the incidence of bladder cancer in women. And to clarify our question, we are investigating adult women, and we are comparing the rates of bladder cancer in women with UTIs to that of women without UTIs. So we performed a systematic search with the shown search key in 4 databases, hoping to find many articles, and our wish was granted with 15,000 articles, which after the process of duplicate removal, title and abstract selection, and full text selection has yielded us 10 eligible studies. Parallel with this, we also performed a reference and citation searching, but found no eligible articles. Now I would like to show you the main results of our analysis. As you can see, we divided our sample of patients into 3 groups according to the number of recorded UTIs they've had. The outcome for each group is bladder cancer, and our measure of effect is odds ratios. An odds ratio of 1 in our case means no effect. A value higher than 1 means that bladder cancer is more common in the exposed group, while a value lower than 1 means that it is less likely to occur in the exposed group. So all of the studies included in our analysis are case control studies with varying numbers of patients included, and also the between study heterogeneity is very high in all of the groups. Well, in the last group, it cannot be interpreted because there is only 2 studies involved, but for the rest it is high. And yes, so in the first 2 groups, which is 1 to 4 UTIs and 3 to 10 UTIs, we showed no effect on the incidence of bladder cancer. But in the third group, where women had more than 10 UTIs, the odds ratio for our analysis is 1.44, which is a clinically relevant number. It means 44% higher odds of developing the disease, and this is also statistically significant. Now, for the good, the bad, and the ugly, our study does have a rigorous methodology, and in the end we did have a high number of patients included, but this came from a low number of articles which have a high heterogeneity between them, and they are all retrospective, and we did have to use crude values in our calculations. But what is the conclusion we can draw from all this? It is that women who have more than 10 UTIs may have 44% odds, higher odds of developing bladder cancer. This, in the clinical setting, implies that these patients may need to be monitored more closely, and that prophylactic methods in decreasing the number of UTIs may have a higher role or a more pronounced role. While on the research side there is still a lot to be done, we are only scratching the surface of this question. We need well-designed prospective studies, and we need to investigate several more factors, because bladder cancer is a really heterogeneous disease. So this is the current status of our project. We are currently writing the manuscript, and we plan to finish it in the next couple of weeks. Our second project is comparing the composition of the urinary microbiome in bladder cancer patients and healthy individuals. It is also a systematic review and meta-analysis. And so this biosis is a disruption to the microbiome, which results in an imbalance in the microbiota. And in the last decade or so, several diseases have been linked to this biosis, ranging from metabolic diseases to a multitude of cancers as well. But causality is still a topic of debate, because most studies are of cross-sectional design. And the evidence regarding bladder cancer is still sparse, so the urinary microbiome needs to be evaluated in the case of bladder cancer. So our clinical question is there a difference in the composition of the urinary microbiome in bladder cancer patients and healthy individuals? Our population would be adults, and we would compare the composition using different metrics in bladder cancer patients and non-bladder cancer patients. And we hypothesize that there is a significant difference in composition. If our hypothesis proves to be true and it proves to be significant, then certain bacteria might be used for biomarkers for bladder cancer, and on the research side, longitudinal studies may get funded through this. So we are still in the preliminary phases of this project. We have a preliminary search key and conducted a preliminary search and identified, well, no systematic reviews and meta-analysis, just one meta-analysis in itself, and there is no Prospero registration currently on this topic. So to summarize, these are the 2 projects that we've been working on, and we plan to submit both of them this year. And I would like to close the presentation with a quote from Confucius, that the man who asks a question is a fool for a minute, the man who does not ask is a fool for life. So please ask questions. Thank you for your kind attention.
Hi. Thank you for your interesting presentation. Can you please go back to the first forest plot of your first project? Because I couldn't help but notice that in the 3 to 10 UTIs group, their results couldn't be different from each other, couldn't be more different from each other. What is the reason? Because it almost looked like they looked at different markers or different stages of cancer. Like what's your explanation? What could be different in those articles?
Yes, so this is a great pitfall of our analysis, that the heterogeneity is really high. There are substantial differences in the study designs. So, for example, in the last study, which has the highest odds ratio for bladder cancer, they have a different age group of cases and controls, which favors the side of bladder cancer as it is more common with age. And while in the study, which is to the most left, they omit a certain time before the diagnosis of bladder cancer, so they omit a time of data. So that's why the association might be weaker. So yes, these are mostly the explanations.
Thank you very much.
Congrats for your presentation. So my question is, when you are talking about bladder cancer, is it in general or it's the transitional cellular carcinoma?
So that's a really great question, because that is something that we really wanted to discuss and show some data on. So we analyzed as our outcome overall bladder cancer, so all histological subtypes included, but we hypothesize from one of the included studies and one other study which didn't get included that that it's only the squamous cell carcinoma which increases in risk, and it is only like 5% of all the bladder cancers, so the increased risk for that subtype must be huge to account for a tiny increase in overall bladder cancer. So yes, sadly we did not have enough data to analyze subtypes.
Thank you.
Congratulations. So there is one outlier in this forest plot. It is 40 years old publication. So I'm not an expert on this bit, but I think the treatment strategy is not the same as nowadays. So have you tried to make an analysis without this article? So because the direction is absolutely the opposite with this article. So
yes, we've tried it, and in all honesty, removing any of the articles doesn't change the fact that we cannot show any effect. So, and I cannot comment on how the treatments were 40 years ago, but I imagine that they were still treated through antibiotic treatments. Yeah, I cannot comment on that.
Thank you.
Was there any age limitation among these articles? So,
generally no, but the study which he just mentioned, which I just mentioned earlier as well, is where the age limit for cases, included cases, was I think 84 or something, and for controls it was 64, which those 20 years are the ages where most of the cases of bladder cancer happen. So this really does skew the data from that article. Other than that, no age restrictions were other than adult women to be included.
Mm-hmm. So UTI and smoking are very common here in Hungary also. What would you suggest? You are doctors and everybody treat patients, remember please. So over 50, somebody smoking, very often UTI, what would you do? Not as a urologist, just as a doctor.
Well, I would suggest for them to stop smoking and, well, stop having UTIs, but that doesn't really work.
For diagnostics, so like a GP or something, if you have a patient, what do you do?
So I would really like to screen these patients, but the data from this analysis is nowhere near an evidence level that we may recommend such a thing. So we cannot perform additional cystoscopies just based on this, based on an epidemiological
as a doctor, as a GP or something, just please with a full bladder, an ultrasound to check the bladder. So this is the most common, a urine test. It can be done by a GP or by a doctor. And after, if there is any suspicion for malignancy, then you should perform a cystoscopy. Okay, just remember, these are some practical tips. I know you are here for science, but maybe you can help some patients with this kind of thinking. Okay, so for diagnosis, an ultrasound and a cystoscopy. And are there any bacteria which can occur bladder cancer?
So again, what?
Bacteria
so bacteria?
Bacteria.
Oh, well, we would have really liked to analyze that as well, but even so, data was so scarce, no article mentioned any particular bacteria. I would go one step further, and I think none of them were confirmed by urine cultures either, so no bacteria.
I have a question. I'm a gynecologist, but you have mentioned that there is a higher risk for bladder cancer in females.
Yes.
Is it true? And what's your opinion? It's because of the higher rate of the urinary tract infection, the shorter urethra, maybe that the higher use of cosmetics,
no,
chemicals?
So the incidence of bladder cancer is high in men. It's, I believe, 3 times higher in men, actually. So, and this is due to the, most likely due to the different habits of smoking. So it's not higher in women, actually.